Hello and welcome to this VetLit podcast. My name is Simon Cook. I'm a criticalist here in the UK, and I'm possibly overexcited to be thinking about all things therapy today with Dr. Alexandra Pfaff. Dr. Pfaff is an assistant clinical professor in ECC at Tufts University, Massachusetts, and is a lead author on a recent study entitled Retrospective Evaluation of Risk Factors and Outcome in Dogs with and Without Fluid Overload During Hospitalization. Dr. Pfaff, thank you so much for joining us.
Thank you very much for having me.
I have so many questions and concepts that I'd love to think through with you. And I suppose perhaps therefore the first question is, are you ready? I think that's probably my first question.
Well, I hope so. I am. Ask away. I'll try to
Brilliant.
answer everything I can.
To begin with, I might ask about this concept of fluid stewardship. Because
Mhm.
if I'm completely honest, I'd like to think that I am a fluid steward, but
Mhm.
I've only very recently encountered the term. So yeah, t tell me about your journey in or developing this concept of fluid stewardship, because for the listeners, Dr. Pfaff has founded the Tufts Stewardship team.
Yeah, it's been a journey over a few years, and I would say I first encountered the whole topic of fluid stewardship when I realized that there was so much insecurity about fluid therapy practice. One of my colleagues, Dr. Rosensky, did kind of an observational study at our hospital a few years ago and realized that a lot of our clinicians think they change fluid therapy plans every day, but when we observed what actually happens, that wasn't really true. And so I started reading a lot about fluid therapy, realized that there's not much evidence out there in veterinary medicine, and then came across the group around Manu Malbrain in Belgium. So it's all the whole concept, I think, at this point is mostly derived from human medicine. There's the International Fluid Academy in Europe. They have a yearly conference that I attended once or twice and was really blown away by what they talk about. They've published several papers about fluid stewardship and what to think about. And so over time, that idea solidified, and I was thinking about doing more fluid research, but also was trying to see if I could recreate something similar in veterinary medicine.
Okay.
And I would say, well, what we've been trying to do is like really a work in progress, and it's keeping me very humble, realizing how difficult it is to promote institutional change and to implement something new. But we have, I think in 2022, we founded what we call our fluid stewardship team, and we try to include different specialties, kind of following the example in human medicine. We included technical staff, we included our pharmacy team, and we kind of were meeting every month, talking about a few studies, ideas that we could have, and have worked on things like creating posters and raising awareness in the hospital. We've done a lot of talks for other specialists, other clinicians, the house officers, the technicians, like really just to start raising awareness of we should look at fluids as drugs. Every
Yeah.
patient should have a prescription. That prescription should be changed at least once a day, ideally more often, just kind of to raise awareness of things that are probably common sense. And I love that you say I consider myself a fluid steward, and a lot of people probably are, but I still believe that we're not as aware of the fluid prescription as we are of other prescriptions.
Yeah. Absolutely. Yeah. Yeah.
And then we also tried with the study that was now published, we looked at a few other things and tried to mostly identify where problems could be in our hospital, and then started to work on a few smaller projects. And to be honest, until IBEX this year, I didn't really realize that other people could potentially be interested in that. Like one little example is that we read a lot about the whole hidden fluids concept, right? Where in people, there's several studies out there now that say that depending on your patient populations, up to 30 to 60% of fluids might come from what they call dilutional fluids that we don't account for in plants, like
Hmm.
for medications, flushes. things like this. And so we started looking at like how significant is that amount for our patients and realized that for big dogs, it really doesn't make that much of a difference, but for small dogs and cats, it really does.
Yeah.
Like we had an average of up to like 15% of their fluid intake from that.
Wow.
And as a result, we started to meet with the pharmacy team and develop this new chart where we tried to figure out which drugs could we maybe dilute less, which drugs could we dilute in hypotonic fluids to at least decrease sodium load, and made a chart. And I just mentioned that at IVEX, and I have gotten so many emails from people asking me if I would be willing to share that chart. So things that I thought were like tiny
No.
things, but people are really interested in it, and that's really good to see.
Brilliant. So then, broadly, people are perhaps more aware, or at least people are trying to raise awareness of the risks of, overzealous fluid therapy, very broadly speaking. But then, are there any other specific components of your plan of attack within the hospital or within the greater veterinary population?
I mean, there's something else that has been getting a lot of attention in human medicine. I mean, which is always the kind of question, which is the ideal fluid, right? What should we use for resuscitation? What should
Yeah,
we use for maintenance? I've been thinking about looking more into the whole topic of reducing sodium load and potentially using hypotonic fluids for maintenance therapy. I know of some colleagues at other institutions that already where that's common practice. They basically have two fluid pumps for each patient. They get
right.
a hypotonic solution for their maintenance needs and the rest for replacement. And I realized I did a fluid workshop a little while ago and realized that there's even like private practices out there where that seems to be common practice. So one of the next things I want to tackle within the fluid stewardship frame is to see if we can get our hospital to change practice and then look at, does this create any changes in electrolytes? Do we see any problems, or is it safe and okay to do?
Yeah. Do you envision in not that many years, we may well be using the genuinely maintenance fluids in our patients in an ICU setting?
I think it will have to be determined because when we look at the human studies, for pediatric patients, there's a recommendation against it
Okay.
because there was a higher incidence of hyponatremia. But right in the UK, when we look at the fluid recommendations, there is a clear recommendations of using hypotonic balanced fluids for maintenance needs. So I think we still need to figure out, at least in research, officially how where our small animal patients fall. Are they going to act like children or are they going to act like adults?
Yeah, yeah.
Assuming, given that a lot of hospitals do this as common practice and continue to do it, that we're probably not seeing problems. But I would love if someone would publish on that.
Yeah. Yeah, brilliant. Okay. And I wonder if we might just clarify then that historically we might refer to replacement versus maintenance fluids, right?
Mhm. Yeah, that's a really good question. So I think, I mean, for us in veterinary medicine, I think, right, we don't really delineate between the two. But when we look at what maintenance requirements of sodium and chloride would be in dogs and cats per day, then our isotonic fluids go way beyond that. So I think that's where the rationale is coming from in people to say, okay, especially if you're on fluids for a longer period of time, we should probably choose a fluid where the sodium and chloride content is closer to what your daily maintenance need is. When we talk about replacement, so meaning replacing dehydration or other deficits or ongoing losses, then right, for a lot of our patients, that means a loss of water and electrolytes. So I think for those, there's pretty broad consensus that we should replace deficits with isotonic fluids. But the question is, should we use lower sodium fluids for maintenance therapy?
For maintaining our patients. Yeah.
Yeah, and what I'm not sure is, I mean, a lot of human ICU patients where these studies are coming from, they're probably on fluids for weeks at a time.
Yeah.
So is this even an issue for us when we're talking about an average of maybe 3 or 5 days of hospitalization and IVID fluid therapy? So those
Yeah.
are all questions that I have and wish to be able to answer.
Brilliant. Yeah. I mean, I think they're answerable, aren't they? With given enough time and with your new entourage of enthused fluid stewards, I think that's totally practicable. Could I ask you just to give us a tiny little tour of the ROSE framework? So this
Mhm.
resuscitation, optimization, stabilization, and evacuation.
I love that concept. Um, as an example, we when we have new interns start at the hospital, they always come to us after a while and they say, "Ugh, I really don't know what to do with fluids. ECC always gives a lot of fluids, and then I'm on internal medicine and they're very restrictive, and I just don't know what to do. Why do they feel so different about fluids?" And I always use the ROSE concept to explain that because you're just catching them at different time points of disease. So I think the ROSE concept really is helpful to it helps me when I try to think about what phase of illness is my patient at. Am I resuscitating a hypovolemic patient? Can I be more liberal in my fluid plan? Can I actually purposefully create a positive fluid balance because I want to restore intravascular volume? Or do I reach the optimization phase, which, if we kind of try to define it, would mean we have a patient that is probably now crossing over to compensated shock,
Okay.
right? So at that point, when I try to think, what does that mean in terms of the ROSE concept, then I think, okay, we might still need bolus therapy, but we need to be a lot more conscientious about the volume we're giving. We should probably use measures of volume responsiveness. Like, do they really need more fluid bolus, or is what they need maybe a pressor or a blood product? But we're probably still creating a positive fluid balance. And then as we reach the stabilization phase, when you look at most of the publications about the ROSE concept, then they will say that's probably starting day two after 24 hours. So that's usually when we think, okay, patient is reliably out of shock, should have been caught up on most of their deficits, and then we're starting to be a lot more restrictive with our fluids. So at that point, the goal becomes to create either a net zero or even a slightly negative fluid balance. And I think that's where the whole I have to be more restrictive with fluids kind of sentiment is coming from, where we then have to really think about, do I still have losses to replace? Do I need to give maintenance fluids? We should at that point absolutely take into consideration those hidden fluids we talked about. How much am I giving that I'm not accounting for? Am I giving nutrition? And then in the evacuation phase, the goal in people is to reduce fluid volume at least 10 to 20% in 24 hours. And I don't know, for us, we probably do that even faster, right? Given that very few patients are in the hospital for a long period of time. But here the goal is really to be net negative, giving them less than they might need, purposefully letting them maybe get a little bit behind as long as they can tolerate it.
Yeah.
And thinking in that concept really helps me because I don't just see a problem in giving too much fluids. I also see a problem in not giving enough in the resuscitation phase. And at least in our hospital, in my experience, very understandably, the less experienced doctors are very cautious with fluids and they're very reluctant to resuscitate. And so, yeah, that is also a conversation I have a lot to say it's really okay in the beginning to give a fluid bolus if they need it.
Yeah. 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 I was yeah, I was itching to ask that question as well. Considering our current or recent teaching practices, do you find that more often now? You find people that are being awkwardly restrictive in the volume resuscitation phase more so than you ever used to see.
Yeah.
Yeah. I wonder, I don't know if you've seen the same, but I think I see it a lot in hypoadrenocorticoid dogs. I don't know why it seems to be those in particular that are people that are very fluid restrictive, and actually they can need a really significant volume of fluids in those first few hours after they present. Anyway, I don't know if you have the same impression, but that's definitely something that stood out for me.
Yeah, the same, I think, I oftentimes have that conversation with DKA cats,
Okay, yeah.
where people are also very, very afraid, but they oftentimes need a lot of fluids in the beginning.
Yeah. Okay. I wonder if we might now move on to your study. Would you be happy to give us a mini tour of your study, or how about the findings that you would want us to take home from it? Because we can't go into it in a huge
Yeah.
amount of detail, as much as I would love to. But what would you want us to take from your study? Because it was a retrospective study, right? Describing those patients that had ultimately been clinically diagnosed or clinically appreciated to be in a state of fluid overload, and those that were not, and then exploring the differences between those groups.
Mhm. So, I mean, first, I should probably say, right, as every retrospective study, it was a difficult study, right? And I think to be careful with how we interpret the results. For me, this was, as you can imagine, we collected a lot of data. It was a monster of a study. And knowing now what I know, I probably would have done certain things differently.
Okay.
But that being said, I think the results are like I was extremely surprised and happy about the results because one thing it showed, again, I'm trying to be very careful to interpret it, but the fact that the study showed that the fluid volume between fluid overloaded and not overloaded patients was not necessarily different, to me is a very, very important finding, which I think we have maybe suspected for a while, and we have given it names like fluid intolerance, but haven't been able to really show that so far. So that to me was one of the more important findings, that it's very important to recognize that fluid volume is very important, but it is also very important what the underlying disease process of the patient, and how that plays into creating fluid intolerance.
And then what about this concept of 10% weight gain? Because
Yeah.
that's the same was true, right? In those two
Mhm.
populations,
Yeah.
or in
So
that population of fluid overload, rather, you're finding that they are clinically overloaded and they haven't got anywhere near this quote unquote 10% that we are aiming to avoid.
Mhm. So, similar. So I was hoping that with the study we could show, this is how we can define fluid overload. We can use the definition of people, and it's great. So, yeah, that finding was unexpected to me. I mean, clinically, what I think, or how I'm trying to explain it to myself, when we have clinical patients, I think if they gain a lot of weight in day one, oftentimes that means they're holding on to a lot of fluid, but that relationship tends to kind of decrease over time. And I think that's probably because, right, they're not eating, they're having catabolic weight loss. And that might have been what made the association a little bit worse because they didn't gain 10% of weight of body weight. So I think we can't really use that as a definition, but the fluid overloaded ones definitely gained at least a little bit more weight than a non-fluid
Yeah,
overloaded one.
yeah. So then, as opposed to, for example, waiting for a certain percent or appreciable chemosis and gelatinous skin and clinical readouts, overtly clinical readouts being evident, what do you think we might be looking for to perhaps spot early a patient that is being fluid overloaded?
I don't know that I have the scientific answer for that yet
Yeah.
because, but to me, I would say it needs to be a combination, right, of repeated clinical assessment, realizing that they are gaining weight. And the struggle, and we actually have many conversations about that in our fluid stewardship team, because if you're dehydrated, per definition, we want you to gain back some, right? But then what is too much? And maybe that was the problem with the study weight gain, is that we were trying to follow the human definition and called it 10% weight gain from non-dehydrated baseline. And that's how it was calculated. But let's be honest, dehydration assessment is so subjective. So maybe that's where the problem is coming from, and we have to find a better way to kind of come up with that baseline weight. Like how much should they gain to catch up on their deficit, and then what is too much. And then repeated clinical assessment, ultrasound. We use a lot of
Hmm.
ultrasound to pick up early on congestive signs. And I think, although I clearly cannot prove causality, I think ileus is oftentimes an early sign as well. Although that is clearly hard to judge because critically ill patients have so many other reasons to develop ileus. But
That would be amazing to know that. I mean, it would be crushing as well to know that, wouldn't it? Given the number of patients that do develop it in hospital. Yeah, wow. So then, yeah, maybe we're gonna have to be spotting the smaller increments in weight gain and just seeing where the fluid is actually going, be that via, as you say, ultrasound and gastrointestinal tract monitoring, etc., etc. Administering a fluid bolus.
mhm.
Have your practices changed in how you administer a fluid bolus at different stages of that Rose framework?
I would say definitely. But I also have to admit that I was still raised and trained in the times where we gave boluses pretty liberal. So I have become more conservative, and I will rather give like maybe slightly lower bolus volumes in the beginning and repeat it if
Hmm.
I'm not where I want to be. And when I think I have reached the optimization phase, I usually try mini boluses to see if I can still get a fluid response and if it is sustainable, bef and rather than giving large boluses. And I'm probably faster to reach for fresh frozen plasma than I used to be if
Right.
I cannot stabilize them with normal crystalloid resuscitation.
Yeah. Yeah, I like thinking about that patient in the well, what if we have an example? What if we're thinking about a patient that is has just come out of theatre, it's had septic peritonitis surgery, it's had its source control, it's recovering in ICU, it's got a trending tachycardia and maybe a slight hypotension or a couple of sort of perfusion indices that are going the wrong direction. In the resuscitation phase, I would have been really happy, just for argument's sake, let's say we're giving 10 ml per kilo over 10 minutes or whatever. And historically, we've been trying to train people away from this idea of giving shock rates and to be giving shock, a bolus and then reassessing. And I absolutely, that's what I've been taught on and been teaching. But in this optimization phase, presumably there is a volume of, if all other things are constant, there is a volume of fluids which could make that patient cardiovascularly stable again. But there's a rate at which you could give it which would be deleterious, and there's a rate at which you could give it which would be ineffective. It makes me think back to the concept of giving them as a rate rather than a bolus over 10 minutes. So I feel like I've gone full circle in those patients. Do you find yourself wanting to, I basically find myself wanting to give that 10 ml per kilo of fluids, but over half an hour or 40 minutes or whatever. What do you think?
I mean, there is, I think, some emerging evidence that would absolutely agree with you, right? 100%. Like some of the glycocalyx studies that start saying that slower bolus volumes might be a little bit less damaging to the glycocalyx. I attended a very, very interesting lecture at IVEX about volume kinetics in cats, where there's a group that's looking at fluid elimination in cats, and they were able to show that cats truly have um, different fluid distribution to the point where slower bolus volumes should be better tolerated by them. So that's actually a concept that I have just started thinking about, giving the bolus volume slower than we used to. When they're very unstable, it's hard for me to give it slow, and that's
Oh yeah.
probably just right what you've learned and what you're used to. But I think there's growing evidence to say we should probably reconsider that.
Yeah. Yeah, I didn't want to dissuade someone from giving volume to an emergently unwell patient.
No,
But
no.
the patient that I'm imagining is this one that's sort of creeping up.
Mhm.
You're really confident that it's volume deplete or the volume is the cause of the tachycardia. Is there a way that I can give it safer than over 5 or 10 minutes? Possibly the answer is yes. Hmm.
And
Okay.
it's so much like, do early pressors maybe help in these cases to recruit some of the kind of venous reserve, or do we really need to reach for colloids sooner? But I don't know, are colloids equally difficult to get in the UK right now?
We have minimal access to any artificial colloids at all, and so we're only using natural colloids. Yeah. Yeah. Great. Well, I might choose to ask one final question just to wrap things up and say, well, you've identified a number of these sort of at-risk populations off the back of your study and promoting the concepts of fluid stewardship, and I would love to be one of your stewards. Um, so what's next for your immediate research or your immediate initiatives inside your hospital? What's the very next thing on your to-do list as we wrap up?
I think the next thing on my to-do list, because it's an easy, low-hanging fruit, is trying to see what low sodium maintenance fluids are doing. Kind of longer term, I would love, but these are kind of pie in the sky dreams. I don't really know how to solve these problems, but exactly the patient population you talked about, the leaky, septic patient that is almost impossible not to overload. What can we do with them to really make fluid therapy safer for them? But do not have the answer of how to get there.
You've got a dream. That's the important thing. Yeah. Excellent. Well, Dr. Pfaff, I can't thank you enough, essentially, for indulging me and for teaching me and our listeners at the same time. So thank you very much for joining us.
Thank you so much for talking to me. That was a very, very informative and nice session.
Cool. The aim of VetLit is to make veterinary literature both more accessible and accessed, and hopefully we've secured that in some small way today. Remember, you'll almost definitely find an article to read that interests you on the vetlit.org site. You can check back here, there, or via the email updates for more, and otherwise have a great day. It's goodbye from Dr. Pfaff,
Goodbye, everyone. Thank you for listening.
and it's bye from me. Bye bye for now.